right. Hey, everybody. We are here with Dr. Jason Smith, owner and operator of Utah Spine and Brain Chiropractic Neurology out in Bountiful, Utah.
That's correct.
Um, and Dr. Jason Smith, he has an amazing background. And for people that don't know him, he's an amazing resource within our functional neurology community. He's been in practice for ever since the late 90s, I believe. And he is not only a diplomate of the American Board of Chiropractic Neurology, but let me pull up more of your credentials here. You have your fellow of the American Board of Brain Injury Rehabilitation, a fellow of the American College of Functional Neurology. You're a fellow of the American Board of Vestibular Rehabilitation. You also have an advanced certification from the Spinal Research Institute of San Diego. And I know recently you and Dr. Rosenthal have been having a blast pursuing your master's in neuroscience through Parker University. So you are very well qualified to be teaching the beginner's track here. And we're super grateful for, your presentation last year was amazing, and all the information that you'll be presenting this year. You present it in such a easy, tangible way. So thanks so much.
My pleasure. It's so great to be here.
And again, thank you so much for serving on the board and helping our community grow. We really appreciate everything. So we're really grateful to have you. Can you tell our listeners and our everyone that's going to be joining us for the conference what exactly you'll be talking about this year?
Well, we've put together a different style of track learning for our introductory certificates here, and I basically had the idea that if we were able to focus on a certain part of certain symptomatology with brain injury, and then just focus on the symptom, on the anatomy, on the clinically, the important structural parts of the brain and the nervous system we need to understand, and then talk about some ways to examine it and then treat it. If we could do that all in one section, I thought that would be beneficial. And you'll have to be the judge to tell me if you think it's beneficial that way or not.
Well, absolutely. I mean, I've seen your notes. I helped out a little bit with the track one course. So I think also two people that took your classes last year got a little preview of what's to come. And everybody said, trying to learn some of this stuff. We've had people with backgrounds in neurology, and they said trying to learn it this way was a little bit overwhelming. And what you did so well was, just like you said, you kind of broke things down to be able to learn it a little bit easier and then be able to apply it a little bit easier, with creating the interest to dive a little bit deeper when necessary. So I'm sure it's going to be awesome.
Well, I hope you guys enjoy it.
Awesome. Well, thanks so much for being a part of this conference, and we will definitely hope to see you in person next year.
I look forward to that.
Well, I'd like to welcome you to the first class of our IAFNR 2020 conference today. I'm so honored to be with you today. Everyone take a deep breath. We finally made it, and I'm just excited. There's going to be so many great presenters. I'm just really honored to be able to share with you some information today. So let's go ahead and get started. We have a lot to cover, and so let's go ahead and share this screen, and we'll pull this up. So we're going to be talking about complaints associated with head trauma today. And we're going to be going for about the next 90 minutes. I'm going to try to keep it quick paced, but I do want to cover a lot of information with you. So let's talk about our learning objectives first. Now, I want you to understand that history determines your exam protocol, and then that result of the exam then determines what kind of treatment you're going to apply. I want you to be able to understand how to basically do a quick bedside evaluation in some cases and a more thorough in others, with basic symptoms such as blurred vision, dizziness, nausea, and lighter sound sensitivity. So the way we're putting these courses together, we're doing it symptom-based, and then we'll talk about some of the neurologic structures that are involved, some of the history things that you'll find, and then how to do the examination, and then how to treat it. It's something that we've never really seen before, but we're giving it a try. So based on the exam, once you've done your exam, then I want you to actually be able to know this is where, along the neurological level of the axis, where that dysfunction is. And then once you know where that dysfunction is, you're going to apply some easy rehab techniques where you can start to get balance in the nervous system, and then you'll start to get symptomatic improvement right away. And then I also want to be able to help you understand how to identify what is too much and what is not too much rehab treatment to apply, so that you're not giving too much stimulation to the patient and causing the crash. So before we begin, I want to talk about this basic needs of a neuron chart, which I'm sure many of you have seen. The left side shows us the healthy neuron mitochondria and the healthy resting membrane potential down here at negative 70 millivolts. And then you see on the unhealthy side, if we have too much lack of activity or lack of fuel, improper circulation, inflammation, autoimmunity, these things all cause unhealthy neuronal mitochondria, which end up decreasing the mitochondria's ability to make energy, which then means people fatigue from normal stimulation. Over on this side, as long as we have steady fuel, appropriate stimulation, not too much, not too little, but just the right amount, and then a way to get rid of inflammation, then I think we can heal and recover from many, many conditions. Even ablative conditions can show a lot of improvement if we give it the proper amount of fuel and activation. Now, you may have seen this before. What you need to know about neuronal mitochondria that get impaired is there's early deficits that you'll see and progressed deficits of mitochondria. The early ones basically means that you don't have as good endurance. So you can start to do things and you're fine, but you stand for a little while and you fatigue, or you read, or you try to concentrate, or you write, or you listen to music, or any of these things, and you start to just fatigue over time, and then you get symptoms. If you have a progressed deficit, that means you'll have more profound neurologic reactions and symptoms with trivial stimuli. So you start to not only feel fatigue with standing, but you get muscle spasms in your neck and back, or you'll get dizziness if you get in a car or get in an airplane. Or you'll start to have tremors when your cerebellum fatigues, easily get car sick. And then, if you have intolerance to MSG, and you can get all sorts of symptoms: fatigue, headache, dizziness, nausea. And then if you get headaches from just simply reading or listening to a conversation or seeing certain lights and smell, then you know that you've had a more progressed neurologic mitochondrial deficit. So our metabolic capacity is really important to understand. The goal with all of our neurologic rehab is to make sure that we give the patient what they can tolerate so that we can start to generate plasticity, but not too much. So if we start to treat the patient, we give a trial of rehab, and we start to have new symptoms or a worsening of the symptoms, then they're not really ready to do functional rehab. If they do a little bit of rehab and they fatigue, you got to look at other things: blood supply, look at what level of the lesion. Sometimes you have to do something presynaptic, stimulate a brain region that's not the primary involved area, but links to it. And then we'll talk more about that as we go along. So just a quick review. Longitudinal level of the lesion, basically, I like to start at the bottom. All of these are functionally connected, but you have a receptor. That could be a pain receptor. It could be a skin receptor, a muscle proprioceptor, but basically all that information from a sensory feedback point goes through the peripheral nerve, up through the spinal cord, to the cerebellum and brainstem, up through the subcortical structures, and then eventually to the cortex. And those are sort of the hierarchy of the lesions. Now, the problem could start with the receptor, the problem can be in the brain, and sometimes the symptom can look exactly the same. So there's certain types of cases that I've found really need particular care. And it's these brain injury cases, acute brain injuries for sure, but then chronic brain injury, post-concussion syndrome, they for sure need to be taken very good care of. The vestibular cases with dizziness involved, they're just, when the cerebellum is unsteady and people are feeling either tilting or spinning, that you just have to be careful. The elderly in particular, if they have a cerebellar demise or a decline, they will also be not as stable. And then some kids, if they have brain injuries, kids are in general very resilient. But once you have this altered neuron and mitochondrial deficits in children, they can be very, we'll call them the opposite of resilience. Fibromyalgia cases, anxiety cases, chronic regional pain syndromes, insomnia cases. These are all cases that you just have to be careful. You can't just go and do the most difficult neurologic rehab that you want to do. You need to, go with care, check and make sure that the patient's not fatiguing, and then add a little bit more and just teach the patient to go easy, because you can do a little and get a lot more ground on the rehab if you start easy. So what are you going to see if you have some metabolic capacity issues? One of the big ones you'll see is nausea. People start to feel nauseated. I mean, we'll talk more about that, what brain structures are involved later, but headaches are a common one. When the pupils dilate, you'll start to see that, they'll dilate, you'll see them tearing, and then people will their face will just loses tone. You'll see them just get really tired. Sometimes they'll want to lay down, or they need to close their eyes for a minute or take a break. If they start yawning, they are fatiguing. So pay attention while you're watching this. If you start to get some of this yawning, then you'll know you're actually getting some fatigue. Now, if the symptom they came to see you with starts to get worse while you're examining them, sometimes you have to break the exam up into different times, or to get them a break, or you have to look at the areas. Once you've done the history, you have to make sure that you set up your exam so you're not just fatiguing the main symptom, the main brain region. Otherwise, you may not be able to do the exam at all. So what do you do if you crash the patient? Well, commonly I've had patients who are dizzy, and we're going to do certain things to either fire the dizziness off or see which part of the vestibular system is involved. And I have to tell them, look, you may get increased symptoms. If you just tell them that, then they're not going to think you're messing up. You just have to let them know. If you feel nausea, headache, surge of fatigue, emotions, or tearing, just let me know right away, and we can take a break. This is an X-ray very similar to a patient that I had who was in a crash coming down the ski resort canyon, Little Cottonwood Canyon, a few years ago, and she slid on some ice and ended up off the road in the ravine, and her arm was pinned and her leg was pinned to the car, and she was there for maybe almost 2 hours, and she ended up, luckily, having her neck fused, and she survived. But in these type of cases where they have some of this type of trauma, you'll find that for some reason, they just get fatigued easily. So what are things you need to look for? Well, you need to observe certain things, and then patients will tell you. You warn them, tell the patient, hey, look, I need you to tell me this. Warn me if you start to feel nausea, headache, or dizziness. But then you watch for these other things. And I will tell you, every single time that I've gotten someone close to the exceeding their metabolic capacity, I've always been able to tell before they really reported it. And most of the time, this happens when I'm doing digital x-rays. If I'm doing flexion extension views on someone that has chronic neck pain or headaches, I'll notice that they'll start to get pale, or I'll feel their temperature just surge in heat, and I'll see them start to sweat. And a lot of times I'll ask them something or tell them to put their arms in a certain way, and they'll just have a very delayed response time, more than it had been a few moments before. And then I'll know we need to get their blood flow back on track so that they don't faint. And we have had a few that actually did faint due to some of these exceeding metabolic capacity. One specific taxi driver, 6'4" guy, we were taking some x-rays, and I just had him do some flexion extension. And then as he looked forward, he saw the picture on my wall, and he says, doctor, I think I'm, and this big guy, I had to just lay him on my x-ray room floor, and he started snoring because he passed out. And he lay there and he snored for about 5 minutes. I had my staff come in, we got his legs elevated, and we were able to get him back, alert, and get his recovery coming back. And immediately when he woke up, he started throwing up. So we had the trash can ready with the liners. And that's really happened twice. Almost every other time I've been able to catch them so they don't fully pass out. But it makes you a little nervous when that happens. Now, I like to measure things. So one thing that I like to do with the patients as a baseline, and then throughout treatment as we're doing therapy, is I like to use a pulse oximeter. Now, there's these cheaper ones that are $30 to $50 that are just sort of the finger type. I love these type over here, which are sort of the ongoing constant. So you see the heart rate changing, you see the oxygen saturation changing. And then I look at the breath rate. Most everyone who has chronic injuries or has brain injuries usually has a much more shallow breath rate. And so you can watch that. And then I look for pupil dilation. You can measure it with some of the apps that are out there. But if it's a fair-skinned person, you can usually see their pupils and their iris a little easier. But as if the lighting's appropriate, you can see that on almost anybody. So there's 3 basic steps to doing appropriate functional rehab. And so we're going to start by just going through these. So first of all, you have to have a history and a thorough review. Once you have a patient on your schedule, before you even see them, you should be able to look through their history, what kind of traumas they've had, what kind of symptoms they have. And you should look at that and go, hey, I think I have a lesion in this area. And then once you think you know where it is, you go ahead and talk to the patient, get further pointed questions that may concern you or you want more information about. But then you're still observing them as they come into the exam room, and as you go through the exam, you fine-tune that lesion localization. And then once you've done your exam, I like to record my exam as I'm doing it, just to state the findings. Sometimes I have a scribe in there, but if I don't happen to not have a scribe, I want her to be able to get all those findings down for my notes. But I want you to be able to say, all right, this is your top 3 symptoms. It's either the cerebellum and the brainstem and the frontal lobe, or in your case, it's the occipital lobe, the brainstem, and the cerebellum, whatever your top 3 are. And those are the 3 areas that you'll start working on. And usually they're related to each other somewhat. So once you figure out your top 3, you need to ask yourself, all right, I already determined the longitudinal level of the lesion. Now you have to think, well, is this ablative or physiologic? I mean, we've seen people that have had strokes 15, 30, 40 years in the past. We know those are ablative, but there's also physiologic dysfunction. So if it's primarily physiologic and there's no ablative injury, MRIs are negative, CTs are negative, then it's probably physiologic. But they can look very similar at times. But one thing I found with these ablative lesions is early on, the deficits that the patient that undergoes a stroke will actually, those deficits will cause what's called a learned helplessness, where they can't use something for a while and then they learn not to use it, and so they don't try to use it. And that's one thing that we like to do in our rehab, is try to get them to use those dysfunctional pathways. So this seems so simple, but you need to think, is it a left occipital lobe? Is it a right occipital lobe? Is it a left frontal or right cerebellar? Try to get as dialed in as you can. And then if it's a pathway that crosses, then where does it cross? Does it cross at the spinal cord? Does it cross at the brainstem? If it's a cerebellar, does it cross above? If it's going from the cerebellar to the frontal, does it cross above there? And then you have to primarily look at, is it motor or sensory dysfunction? And then the last thing, which is what we're going to just weave through this whole conversation, is, are there autonomic concomitants? Things that show you that there's not getting fuel to those areas, and that's why they can't function properly. All right, so when you're doing your functional rehab, what you want to do is you start with the trial of treatment. Once you've done your history, you've done your exam, and usually while I do my exam, I'll repeat some of those tests several times and see if they get better or if they get worse. If they get better, then that's usually an area of the brain that we can really work with. If we test it and it gets worse and it gets worse and it gets worse after 2 or 3 tries, then that's an area that fatigues too easily. That's probably not the best approach to rehab. So you look at their fuel delivery, and in my situation, obviously you want to make sure that people come to your exam where they have eaten in the last few hours. A lot of times they're like, I didn't feel good, so I'll just skip my breakfast, and then your exam's at 11 o'clock, and now they haven't eaten in 18 hours, and they just don't do well. So you want to make sure that they have eaten something within the last few hours. And I always check breathing, because if you look at that breathing rate and it's fast and the rib cage expansion is shallow, they're not going to get the fuel they need to their brain. So once you assess the fuel delivery and you're moving to the next step, which is making some goals and recommendations.
And then you set your goals. I usually talk to the patient about treatment goals, usually their top 3 as I'm doing the consultation. But as I'm winding down through the exam, I'll state what further tests need to be done, and then we'll review what their goals are that they talked about so that they know that we're on track with what their goals are. So let's talk a little bit about neuroplasticity. Now, Hebbian plasticity is basically back in the 1940s, Hebb put out this postulate that if you have coordinated activity into a neuron, the presynaptic terminal connects with the postsynaptic, you'll actually strengthen the synaptic connection. But on the other hand, if you have uncoordinated activity, you'll actually weaken your synaptic connections. And then this is the famous quote, neurons that fire together, wire together. So I really like this video. It's a quick little video that just shows some really cool, you see the time lapse on the bottom right corner. It's going really fast, but this is a 170-hour time lapse, and you basically see these little threads and all these connections just being made. I don't have a ton of detail on exactly if this is human or animal or what, but I know that there's a lot of neurons that are growing and connecting here. And one thing we'll talk about is as far as human neuroplasticity is concerned, a lot of that research was started with animals back in the 60s and earlier. But what we find is research on the adult human hippocampus shows that we are regenerating neurons and we have to exercise them in order to maintain them. So let's review some of the basic principles of human plasticity. Now, there's my cute little granddaughter right there practicing the piano at age 1. She's now about 2 years old, but she still loves music and she loves to play. And that's one thing about neuroplasticity is that if you use something or don't use something, then the unused cortical area in that region gets invaded from neurons from nearby areas. So that can happen in brain injury, it can happen in stroke, it can happen if you just don't use your skills. You know, if you think about it, you know, I played the piano as a young child. I took lessons for several years and then didn't take for a while. And then as I got older, I started playing again. And it's just not as easy to play when you haven't played in a while. Number 2 basic principle is that if you increase your use, you expand your cortical map. And basically cortical map is just the way I look at it, it's just real estate. If you have increased real estate, increased sensory feedback coming to a zone, then you're going to get more growth of those tissues. And I'll show you some charts in a minute. Now, the 3rd basic principle, and this is all from Thomas Elbert's quote in Human Neuroplasticity from a 2001 study. And he said that synchronous inputs lead to fusion of cortical zones. So that's why I put the picture of the duck's feet up there. So when the duck flaps its foot as it swims around, those areas go to a similar area of the brain in the duck's cortex, and probably don't have a lot of independent actions happening in that duck brain. And then principle 4 is that asynchronous input leads to segregation of cortical zones. So if we have fingers that move differently and separately, it's much easier to have the brain control that, and they'll be linked. But if they're not synchronized, then you'll have cortical zones that don't link. So here's a image from this a different study, neuroplasticity across the lifespan, and you'll see there's a purple neuron over here and a green neuron, and it's firing to this black neuron. And basically, if the purple neuron fires right before, within milliseconds to the black neuron firing, and it does that multiple times, then that synapse becomes strengthened. If the purple neuron fires not within a few milliseconds, maybe half a second, or maybe it's more than a few seconds separate, then you don't have really any change at all. But if you have a firing where the purple neuron fires right after, not right before, but right after, within milliseconds afterwards, and that actually weakens the synapse. So that's what they found with the animal research and in humans as well. So here's an example of some plasticity happening with
a monkey brain up in this upper left-hand corner, and you'll see the organization before the stimulation. It was just took this cortical real estate. It looks like a map, just a small little European country right here, or maybe a small state. And then what they did is they stimulated the tip of the second finger for 1.5 hours a day, just stimulated that over and over and over. And you see the scale is a 1 millimeter scale. So here it was less than a millimeter of cortical real estate. And then after 109 days, stimulating the tip of that second finger on the monkey, you get all this expansion of real estate occurring. So that's really what we want to try to do, is we want to localize the areas that need that kind of stimulation, and then stimulate it and have the patients do it. Not every day in our office. Maybe when we get started, we have to do more of an intense sequence of care, but later, the thing that will cause lasting change is them doing their rehabilitation on their own at home. So there's 4 basic categories of brain injury symptoms. We're going to move into specific TBI now, and these are specifically mild traumatic brain injury. But if you've treated any of these, you know that these are the basic categories. It starts with too much or too little sleep and easy fatigue. And that's very common in the literature. As soon as you have a brain injury, immediately after that brain injury, you have an increased demand. You need more fuel to help heal those damaged tissues. But at the same exact time, you have decreased fuel, decreased blood flow. So that's what's called a metabolic mismatch. And if you have more demand and less supply, you just create very rapid onset of symptoms. So from the physical side, headache, nausea, vomiting, balance problems, tinnitus, visual and light impairments, sound sensitivity, coordination issues, and dizziness. So we're going to talk about these ones that are under the asterisk here. We'll start by talking about some visual impairments, and then we'll move into some of these others. So I like to remember these 4 common categories, because almost all the symptoms that patients complain of will fall under these 4. And usually if they come in, say, with brain fog and really difficulty concentrating, and you ask them, oh, have you noticed your emotions, you're impulsive or irritable, or you just don't, you get too aggressive, or you just don't care about anything. As you start to put their story together during the consultation, you'll help them understand that it's really not just one of these that gets involved. So what we're going to talk about with this section is those things I just mentioned. We're going to start with blurred vision. So when you talk about visual disturbances and blurred vision, the literature is very clear. You need to be able to analyze not just when someone complains of blurred vision or double vision. I've even had patients that complain of triple vision. I don't know how she did that. She only had 2 eyes. But you have to find out if it's a visual acuity issue or it's an oculomotor issue. And you know, there's a few differentials. Obviously, they're going to tell you they have some blurred vision, but there's a lot of things that can happen in motor vehicle collisions, in sports injuries. There's inertial injuries happening to the brain, and there's also impact injuries that happen to the brain. But the differentials are very clear. I've seen many of these. Usually, a lot of these have been already dealt with and managed before they come see me. But retinal detachments are common. A lot of times people with traumatic brain injuries have dry eyes, or they've had them for years, and then they get a brain injury and it makes it even worse. Sometimes their eyes can be hit, or you can have corneal or chemical abrasions from chemicals from airbags. And then, of course, if they hit the back of their head or the front of their head, there's a contra coup issue, and you can have frontal or occipital trauma, which can lead to these visual issues. If the brainstem is imbalanced, there's oculomotor findings. You also need to be aware of any of the more sinister conditions like hypertension and stroke. So those are going to happen more if there's a sudden change in symptoms. So anytime people have blurred vision, you don't just want to say, oh, I have blurred vision. Well, when do you notice it the worst? Is it when you're reading more? Is it more when you're walking and you're just looking in the distance? Is it when you're looking at your phone or the computer close up or reading a book? Or if you have moving targets, say you turn a corner or sit in the back seat, you have to ask, when do they notice the blurred vision? And a lot of times they say it's all the time. I just feel it all the time. So you have to ask those questions. So I've dialed out some of these peripheral structures and central structures. The reason I do put together these charts is sometimes you sort of get confused as to what's peripheral and what's central. And obviously anything that's central is going to be anything that's specifically in the central nervous system. The peripheral structures all feed into the central, and then the central, of course, has an outgoing pathway, that a motor pathway to the peripheral structures and glands. But if you look at the cornea or the ganglion cells, or the optic nerve or the optic chiasm, technically, if you want to be super technical about it, the retina, it actually is comes from brain, so you can actually look at the retina and actually see the brain. But the central structures, in the thalamus, you'd see the lateral geniculate nucleus. Hypothalamus is really important, and then the pretectum, which is your superior colliculus, and your areas that actually interpret and go to the secondary areas, the primary visual cortex. So here's an image of that, and basically you'll see images coming through. You see it coming on this side, and then of course the nasal field, which is the temporal, from the temporal side, comes across, and then it crosses to the opposite side of the cortex, whereas the light that's coming into the temporal field of the eye ends up staying laterally and ends up on that same side. But you see the optic radiation, and all these white matter structures can all be sheared and have micro trauma in brain injuries, whether they're inertial or impact injuries to the skull. So when you look at the pupillary light reflex, it's really important in order to help us focus. So if you look closely, you'll see this is an inferior view of the brain. And so this would be if we're looking at underneath, this would be the right eye. Yeah, that's right. And of course, you see the ciliary ganglion, which comes directly from the Edinburgh-Westphal nucleus and comes up sort of next to, travels around, and then that controls the contraction and relaxation of the muscles that move, that change the length of the pupil, or excuse me, of the lens. So superior colliculus. I always like to ask questions just to keep yourself oriented. So remember, anytime you see the colliculi, you're looking at the back of the brainstem, and then when you're looking at these ventral tegmental areas, they're more towards the front. All right, so with blurred vision, if you find, in my scope of practice as a chiropractic physician and a functional neuroscientist, I'm basically, if there's a specific large visual field cuts, if there's large tropias and phorias, if there's significant convergent spasm and vertical nystagmus, I'll usually refer those out just to make sure that we're not looking at anything ablative. But anytime visual acuity is involved, I'm just going to send those out to a qualified visual therapist, optometrist who's trained to do that. So what you want to do with these blurred vision cases is you want to rule out refractive errors. And the two main the ways we do that are with just a Snellen chart. You can use the short one at arm's length, or you can use the bigger one at 20 feet. And then I like to specifically do the head impulse test and the dynamic visual acuity test and the corneal blink test in these cases. So I'll go over how to do that. So dynamic visual acuity test, 4 simple steps. You basically want to find out what their static visual acuity is at baseline. And then what you'll do is you take their head, and I'll show you a video in a moment, and you just move it 5 to 10 degrees at 2 hertz. So I like to get a metronome, make sure it's not going too fast. Some of those you'll find on the internet, they're moving their head really fast, but passively, meaning the doctor has to move it. So you say, focus on that, read the line that you can read. And then you say, all right, what's the one you can read? And you have to make sure that you're not using, not letting them just memorize the words and the letters, excuse me, the letters. So sometimes have them read it forward, sometimes have it read it backwards. And this literature says that if they lose 3 lines, they get worse with 3 lines from static to dynamic. That's significant. And that means they suggest vestibulo-ocular function loss. So here's a little video showing a therapist tilting the head to 30 degrees. And then you're just having them look at that thing in the distance and read the chart that they can see. Just takes a moment. And then I like to have them do the head impulse test. This gives me a lot of information on which side. One thing I notice is patients who've been to other practitioners, maybe a physical therapist, a lot of times they're getting they're getting bilateral exercises, but the patient's complaints are on exam findings, they're very unilateral. So I like to find out what side, if there is a side that's more dysfunctional. So watch this video and see if you can tell which side is the dysfunctional side. Let's go back there.
Your head go nice and loose, okay? Look at my nose and keep your eye open.
So he moves quickly to the right and quickly to the left.
Keep looking at my nose. Look at my nose, okay? Switch on this one, okay? Look right at my nose. Okay. Look at my nose.
So if you notice, as he turns her quickly to the right, she's able to maintain focus. As he turns her quickly to the left, she loses focus. So in this case, which side would you rehabilitate and how would you do the rehab for that case? You know, we're once again assuming you did your history, your examination. Now you're like, I need to try and see what I can do to make this function improve. So if she has well, I'll show you when I go over the different treatments. So here's our treatment considerations sheet. So what I really like to do is I like to have people, I have a whole bunch of stickers from when I started practice. I have just piles and piles of these stickers I used to put on the manila folders. And I've been in practice over 21 years and I still have extra stickers. So I just give those to patients, give them different colors, red, green, yellow, blue. And then I have them put them about 1 inch apart, but I have them do it in the format of this clock. So I have them put a sticker at 12 at the center, at 3, 6, and 9. And that way I can have them start looking at the center of that. And if you watch my eyes, I'll get a little closer, and you just look at the center, and then you just turn 5 to 10 degrees, and then you stop. And then you look at 3 o'clock and turn your head 5 to 10 degrees, and then you stop. Just do a couple no-nos, and you go through each of those sections. It may take 20 to 30 seconds, and you've done 1 round in 1 session. And then you might have them do that every hour. I've had people do it sometimes 10 times a day in order to get their system dialed back in, their vestibulo-ocular system. And then once again, you have to avoid overstimulating them. Sometimes people like to do it really big and really fast. And if they do that, they'll find that it doesn't help. It will usually make it worse. If they can't do 30 seconds, you know, they may not be ready for this kind of a rehab. But every eye movement dysfunction that I've seen, it usually involves the brainstem at some level. And so usually if you just slowly stimulate that, if they can't tolerate it sitting, then lie them down. If they can't tolerate it lying down, have them lift up their legs a little bit so they get more blood flow to the brainstem, and that usually helps. So the next thing I want to show you is how we do the corneal blink reflex test. And there's a correct way to do it and an incorrect way to do it. When I learned this in school, they didn't really teach us properly, but you know, I just want to make sure you review it. So you see, you're touching the area that's colored, but not on the pupil, and you're not doing the white area. So you want to actually twist up a piece of tissue. Sometimes I'll have the patient do it. I always make sure my hands are clean so we don't spread infection. But we will just touch the corner of that eye with the tissue, and we're just looking for a blink response. Now, one thing you have to be aware of is sometimes people don't have a normal blink response because of their used to putting contacts in. So let me just show you one here. And so I just touched her iris there. Didn't get much change. Trying to get in the actual.
There we go.
So her left side had a little bit better blink response. I didn't quite get it where I wanted to because I was trying to not get in her field of vision, but you can see that it was not as good blinking on the right side. So then we'll look at one more.
Look at that dot.
Right eye. Tell me which side is abnormal. So I stick it on there and then we move it around a little bit. We got a delayed blink. And then this one, I'm dragging it in there. We got a delayed blink again. So she did wear contacts, but her blink response was compromised. So the blink reflex is basically a two-arm reflex. It starts at the cornea, goes down through the ophthalmic division of the trigeminal ganglion, and it goes down to the lateral tegmental field here. And it does have linkages into the spinal cord, because what you should see when you have a proper blink reflex is a bilateral blink, a withdrawal, some kind of a pullback, and then a tear that starts. And then once it gets to the nucleus here, the facial nucleus, then you actually, that's the motor component. And then it goes around the abducens nucleus and out, and it should go to both sides. So it should go to both sides, and when you stimulate one side, it should cause both sides to blink. So that's a very common thing I find. What do you do if someone's not blinking? Well, usually they start to go, wow, that is weird. I usually blink. And then a lot of times they'll tell you they have dry eyes as well. So their glands usually aren't making appropriate tears. So if they have a loss of blink reflex, it can mean a lot of things. It could mean they have brain injury. It could be happening from neuropathy in the brainstem, or the nerves going to or from. It's common with acoustic neuroma. Multiple sclerosis is a big one, and if they have the Wallenberg syndrome, they'll usually have some hoarseness and swallowing difficulty as well. So what are some alternatives if you don't want to roll the tissue up and you don't want to worry about getting an infection in their eye? Basically, you can use some sterile saline, just lay the patient on their back, and you just get a little syringe, and you just have them hold their eye open and just put a couple drops, 1 or 2 drops in there, and if their blink response is normal, it should blink right away. The only thing, you don't get to see the tears that well. The other thing that I've tried quite a bit, just as a sort of a double check, is I do the insufflation bulb with the otoscope. And then I just, once again, have them look. So if I'm doing the right eye, I have them look up to the left, and I have them to look at a target on the wall. And then I hold that there, and then I just put it out of the field of their vision, just give them a little puff, and it'll usually make them blink. I also like to do that for therapy if the patient doesn't tolerate some of these other therapies I'm going to talk about. So if that, once again, we're going to review everything. So we talked about blurred vision. We talked about if there's a refracted error, meaning they don't have proper acuity, then send them for a vision therapist. They can use prisms, or they can correct their vision. But if it's a vestibulo-ocular function, we can actually exercise that. The over-dilated eye is common because the autonomic nervous system is so sympathetic dominant. If they can't constrict, then you have to sometimes use blue blockers, and we'll talk about some of those in a minute. Now, if the corneal blink is decreased, what I usually do is a unilateral, I choose one side that's the worst. Sometimes it matches with their cerebellum side, sometimes it doesn't. I just choose the one that's the worst. And I'll just use some Sombra, a little gel, little cream, put it near the eye. just right near the corner. And then we have them put that on a few times a day for about maybe 10 minutes or so, maybe 15, until they start to get some tears. And that irritation is, remember, it's not in the eye, but near the eye. And we just stimulate that 3 to 10 times a day, add the no-nos if they need it for the vestibulo-ocular function, and their brainstem starts to come alive. And it really makes a difference for their symptoms. So if you're testing the patient and you're worried about metabolic capacity, well, what are you going to see? If they're like, you're testing them and you try some things and then they just get worse, you may not be able to do a full evaluation. But usually these exams I just discussed are pretty quick, so you can get them done easily. If they start really tearing, I've had people just really start tearing up where they have had dry eyes, and we just turn that water faucet on, then it may be starting to exceed their capacity. If they start dilated and they dilate even more, or they start blinking a whole bunch, or they get a headache, nausea, or dizziness, then you just have to sometimes lay them down, turn off the lights, and stop the stimulation. So let's talk about dizziness for a moment. So what are some common history scenarios that can lead to this kind of complaint? Well, we're talking about brain injuries. That's common. Acute and chronic whiplash. A lot of times there's cervicogenic dizziness cases, and the research is showing almost we'll call it 95% or higher overlap of symptoms from brain injury and whiplash. So you have cognitive issues, you have pain, you have balance issues, and whiplash can cause the same exact issues that brain injury can cause, which may mean it's really hard to get a whiplash without having a brain injury at some level. Diabetics with small fiber neuropathy also tend to get these dizziness symptoms. And then really commonly in my practice, people who are over 50, maybe 55 and up, they slept wrong, they just turned over in bed and they got dizzy. Canalithiasis is really common. And then probably there's over several hundred medications that have a side effect of dizziness. So you have to ask about that when you have a dizziness complaint. So there's 4 main categories of dizziness. There's the first type, which is basically an illusory movement, and it's related to the vestibular system. But usually they're feeling severe spinning. It's pretty intense. A lot of times they're tilting, and there's a lot of times nausea with that as well. Now, the other category, second category, is presyncopal lightheadedness. And basically this is when the patient feels like they're about to faint. A lot of times they'll have tunnel vision. They'll sort of not be able to hear, and it's usually from a drop in blood pressure or postural tachycardia, which usually doesn't have a drop in blood pressure. It just causes a severe elevation of their blood, their heart rate, their pulse. The third type of category of dizziness is multisensory, and that's usually when there's multiple systems involved. There might be a neuropathy or something in the spine, neck, along with something in the inner ear, along with something in the cerebellum. And it's really common with the systemic dysfunction, diabetes, people who have had chronic pain, and people who just aren't very active, or have had recent trauma. Then the final one is the fourth category, psychophysiologic dizziness, is when these symptoms include visual vertigo and space phobia. So these are the type of people that they get in big rooms with a lot of people, and it just gets over, the motion of the people overwhelms them, or they get maybe in the grocery store and you've got lines and stacks of groceries and different things, and that can really throw them off. Also, people who maybe might get in a high place, they don't like it. Stadiums with these, which we haven't been in stadiums for a while, but stadiums with these sloping views and these massive light shows that go around can trigger sometimes this psychophysiologic dizziness. So what structures are involved? It's pretty simple. Central structures, pontomedullary brainstem, it's where the vestibulocochlear nerve comes in, the cerebellum, and the parietal insular vestibular cortex, PIVC, is the central. And then the labyrinth, the vestibular labyrinth, is fluid filled. The maculae And the vestibular ganglion and nerve basically leads into that structure. So here's a labyrinth in its innervation. You see the semicircular canals, and you see the cochlea, and then you see the saccule and the maculae right there. And then each of these has a nerve that goes to combine into so these 5 different organs, vestibular organs, combine into a vestibular nerve. There's a Scarpa's ganglion, and then it travels right through with the auditory portion of the cranial nerve 8, and then the facial nerve as well. So when we look at how the semicircular canals are oriented, we know that they're approximately 30 degrees tilted. So if someone's lying supine and you wanted to isolate the horizontal canal, you would want to tilt their head forward about 30 degrees, but maybe one side's 28 and the other side's 32. It's not always perfect. But inside the end part, let's go back to this area here. You see this ampullae. And the ampullae is where we're looking at right here, the ampulla. And it has this sail-like structure that has the hair cells that come up through it. Of course, this is all fluid-filled inside, and it's fluid-filled outside. So it's the way I like to look at these bony labyrinth is like an underwater cave, underwater tunnel, which opens into an underwater cave. And inside the underwater cave, you have the bounce house. And so there's fluid outside of the bounce house, and then it's fluid inside the bounce house. And in the inner ear, as far as that's concerned, we don't want those 2 fluids to mix. They have different chemical compositions, and if they mix, it will cause immediate dizziness. But you see, as the endolymph flows to one side, it causes a bend, and it will increase the feedback on one side. Say it's the right posterior canal, it'll increase that feedback, and then it'll decrease the feedback on the left anterior canal. Same thing on the opposite side. If you turn to the right, you'll get a right horizontal stimulation on the right horizontal canal, and you'll inhibit the left at the opposite at the same time. And then as you see these coming into the central, we see the pontomedullary area. As it goes up, it crosses over. There's all sorts of feedback loops to get the 3rd, 4th, and 6th cranial nerve to control the 6 pairs of eye muscles, and then it crosses over to the thalamus, and then it goes up to the vestibular area of the parietal lobe, parietal cortex, which I already mentioned. So there's a lot of feedback loops. There's downward going tracks, there's upward going tracks, and this diamond-shaped nucleus is the vestibular nuclei, and there's a superior and middle and an inferior and a lateral on each side. So these projections, as you can see, these projections come down, and from the medial, they come in from the vestibular organ, and they synapse here, and then there's synapses that go down both sides to the ventral horn to cause spinal motion, and then there's also upgoing input and lateral input that goes out to the cerebellum, to the flocculonodular lobe. And that basically, the cerebellum is what integrates, along with the vestibular nucleus, all the vestibular input we have. And the cerebellum is so dynamically plastic that if you slice one vestibular nerve on one side completely surgically, within a few days, that cerebellum can adapt and balance to that tone. And I think what I've seen with so many of these elderly patients who come in with canalithiasis is the cerebellum just can't adapt as well as it used to be able to. And it's not getting as much feedback from the legs and spine. It's not getting a lot of motion in the head. And so the cerebellum actually loses its ability to adapt. So what do? Well, you want to do a focus examination on people with dizziness. You do a coordination exam, and sometimes you can't even do the full exam if they're too dizzy. But you want to specifically do a Dix-Hallpike and a supine head rotation. The Dix-Hallpike will help you determine if it's a posterior canalithiasis, and then the supine head rotation will determine if it's a horizontal canalithiasis. And then of course you want to do your H in space for the bedside ocular motor examination. So the coordination exam is, you see that beautiful, just extraordinary, all these villi here. I love the cerebellum, and it just has so many connections. As you read in Kendall and Schwartz, they talk about the cerebellum has maybe 40 times as many neurons and connections as the whole rest of the brain. So if there's 1 million neurons in the brain, there's 40 million in the cerebellum. It's amazing how many connections there are. And what it does, the coordination exam primarily tests the cerebellum. We're looking at motor learning and timing, which is everything in balance. It also fine-tunes muscle activity. And then the main symptom we look for is ataxia, dysmetria, or decomposition of movement. So let's look at the 3 functional divisions of the cerebellum and how we test those. The vestibular cerebellum, this is sort of an unwrapped model of a picture of the cerebellum. And you see it's sort of wrapped around, and underneath you'll see, you don't even really see the vestibular cerebellum from underneath very well, but there's the nodulus and flocculus, and that's why we call it the flocculonodular lobe. And then you'll see the, to test it, you're going to look at end gaze nystagmus, and you'll look for truncal tremor. So the way we look for that is we just do an H in space. So you just do the H, you just have them watch your finger, make sure they're not converged. They're at eyes distance apart. They look at it across. So they're pursuing back and forth a few times. Then we have them look up to the left, down to the left, up to the right, down to the right. And that's their H in space. And then you hold at the end gaze and see if they have nystagmus there. And you'll just sometimes see a couple beats, and sometimes you just see them give up. They won't keep looking at it. So for the spinal cerebellum, the main symptoms you're looking at is ataxia, wide base gait, once again truncal tremor, and then I always test with tandem gait. We just have them do sort of a Romberg's test with the sharpened Romberg's. We just have them stand with their feet, one touching the other heel to toe, and then I have them usually put their hands on their hips, and then we just see, can they do it for 10 seconds. And then you do it with your eyes open and eyes closed. But the wide base gait is very obvious. When they're walking, you'll see a lot of truncal movement going side to side, and a lot of that's very common when they have very weak hips as well. So here's a patient that gave me permission to share her video. Young gal, has scoliosis, and she closes her eyes. I mean, there's just not a lot of cerebellar control. If you watch that, when her eyes, even when her eyes are open, she's still not upright. So I had her put her feet a little wide apart. As soon as she closes her eyes, she's just losing control there. So the next functional division of the cerebral cerebellum is common, and it's involved with scanning speech. So almost like I just did there. I still didn't finish my sentence. My voice sort of trailed a little. But that's called dysarthria. And also we look at supination, pronation of the hands. And if they're dysfunctional, that's called dysdiadochokinesia. And then we look at finger to nose testing. So spinal cerebellum is going to be right along the midline. Vestibulocerebellum is tucked underneath. It's the smallest area. And then the cerebral cerebellum is more lateral. So here's a video of a patient who we were doing some supination, pronation on his right hand. And then if you look at, he's also doing a lot of mouth movements as well, trying to get enough cortical activity to generate that pulse. He was okay, but it was definitely harder for him to do it on the left than the right. So here's another one for the cerebral cerebellum. This is a patient who had had a stroke and then got in a car accident and came to see me and had lots of pain, lots of dysfunction on his left side. At this point, you see how his hand is still in the contracted position. And that would be an intention tremor. So there's definitely some cerebellum involvement there on the cerebellar. So then we He happened to be wearing the same shirt. This is a few weeks later. So then we have him do some finger to nose work. And his right's pretty good still. Left, a lot better than it was. Much more accurate. So you're probably wondering, okay, what was the amazing trick we did? Well, in this case, I told him to, he didn't speak, his primary language wasn't English. He didn't speak English very well. And I told him I want to do a certain bouncing ball activity, you know, 1 minute every day, like maybe 5 to 10 sessions a day. But what he ended up doing is he did the exercise for 10 minutes, 5 times a day. And so when he came back the next visit, so here's what he was doing. He was able to actually open and close his hand much, much better. And so I was just having him do this ball bouncing activity with primarily his left hand. And one thing I know that they need to do it is when they drop it like that. So he didn't have super good coordination. He was able to do it a few times, but then he just lost it. So I had him work on bouncing that ball with a metronome, and he's literally did it 10 minutes 3 times a day. And he came back and his cerebellum was basically rehabbed a couple days later. So one of the ways I like to help doctors remember not to miss certain parts of the coordination exam is look at this mnemonic Danish. So look for dystatocokinesia, the supination, pronation of the hand. Look at it both sides. I usually like to do them one at a time and have them flip-flop it. Have them just do it 5 or 10 times really fast. Sometimes their dominant hand will be worse, and sometimes their non-dominant hand. Usually it's, I just call it the cerebellum on that side. So if we look at their gait and they have ataxia, then they'll have a wide-based gait, and then they'll have not smooth walking usually. Nystagmus is common. Intention tremor, we saw that where you get close and you start to lose your smoothness. And sometimes they decompose, they move like this, and then they eventually get there. Slurred staccato speech is common, and then hypotonia. So I do check this all the time, but basically with the rebound test, you just have them hold their arms out and you just push, 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 and then relax. And you look for how far it recoils. And sometimes it won't recoil at all. The decreased tone is usually the cerebellar side that's involved. So what do you do? Remember, we're talking about dizziness, and cerebellum is the main central structure that helps integrate the vestibular and the somatic input. So if it happens to be a semicircular canal, and there's research that shows so often with whiplash soon after, within usually weeks to a few months, they'll have a canalithiasis that occurs. And so the Dix-Hallpike maneuver is what you use to determine the semicircular canal side that you need to treat. So you're just looking at the posterior canal. And a lot of times I'll tip the patient back and they're not that dizzy. And then when they sit up, they get way more dizzy. So could be a frontal anterior canal, or it could just be, it takes a while to get those fluids to move. But remember, when you're testing for horizontal head rotation, just lay them supine, elevate the head 30 degrees, turn it to one side, hold for 30 to 60 seconds. And a lot of times you'll just see that nystagmus start. You know you have to do a horizontal canal maneuver. So how do you do the Dix-Hallpike? You basically just start them seated. I like to put the Frenzel goggles on so that they can't fixate, because if it is a peripheral canal, if their eyes are open, even though a lot of people like to close their eyes when they get dizzy, if they fixate, it will suppress the dizziness. Now, if it's really acute, there's nothing they're going to be able to do. Eyes open or closed, you're going to be able to see that motion. But I like to put the Frenzel goggles on. It just blurs their vision so they can't fixate as well, and then I can usually see the nystagmus better. So you just start them sitting up. I usually have them hold my arm nice and secure, and then I just warn them this is going to be really, they might feel dizziness, and they just tip back. When their head's turned to the left, their head's hanging back over, we're testing the left posterior canal. Excuse me. If their head's turned to the right, we're testing the right posterior canal. If their head's turned to the left and tipping back, we're testing the left posterior canal. and then that would be the side you start on when you do the correction. So if you tip them back and they start to get this torsional nystagmus that's beating towards the ground, then, and they're tipped back to the right, that's usually the side we'll start with. Same thing with the positive on the right. If we turn their head to the right and they start getting that beating nystagmus, that's how we'll usually decide, that's the position we start doing the correction. So you got to teach people how to do this. I had a patient who called me on a Sunday, a friend about an hour out of town, and he was telling me about this dizziness he had. And I was saying, well, here's what you need to do. You need to do this and do this and do this. And then I'll you know, hopefully you can feel better and we'll get you into the office tomorrow. And so he did it as I was explaining it to him. And as he sat up, he was basically felt better. And his dizziness hasn't ever come back. So a lot of times one of these maneuvers will be enough. In people who are younger, it can be enough. In people who are older, more chronic, more brain central issues, they'll usually need to have, you know, usually 1 to 2, maybe 3 of these treatments. So they basically start sitting on a bed, you tip them back, their heads tipped to the side and slightly extended. This doesn't really show the extension. And then they just hold it there for about 30 to 60 seconds. And then they turn it 90 degrees. And then usually they have to be prepared to have some dizziness as they go to each of these different positions. And then they lay on their left shoulder, their heads down to the side. You see there, this would be for a right posterior canalithiasis. And then as they sit up, I have them keep their chin down as they sit up, and usually they have to be prepared to get even more dizzy. At that point, they sit up and I just tell them to avoid looking up for about 48 hours, and I try to have them sleep elevated to 20 or 30 degrees just to avoid stimulating that. And basically, you're bringing that otolith, calcium carbonate crystal back into the central vestibular labyrinth so it can be reabsorbed. Now, if they test positive for horizontal canalithiasis, basically what you want to do is have them do the log roll, and it's pretty amazing. I usually don't have them lay all the way on their side. I just have them turn their head. And they're laying on their back. The bad ear goes down, and then you have them go up 90 degrees, then they turn 90 degrees, and then I just have them turn right on the exam table, lay on their stomach, and then we turn them all the way around. So it goes 360 degrees, and then we have them sit up sideways from here, coming back up. So there's a lot of controversy whether or not vibration of the mastoid adds to the efficiency of it, the efficacy of it. But at this point, I like to do it because I want to try to speed things up, and I think the vibration helps give more feedback to the proprioceptors and the muscle spindle, and so I think it actually helps feedback to the cerebellum, helps them recover quicker. So just to review, when we're looking at the oculomotor exam, we look for a couple things. I forgot to mention one on here. We look at pupillar constriction. We want, when light shines in the eye, we want the pupil to be able to constrict. Several TBI cases, it's more the rule than the exception. You shine a light in their eye, it'll start to constrict, and then while the light's still on, it'll blow out. And that's just a sympathetic dominance. We look for the pursuits, they're H in space, and then I have them look side to side at a finger that's, maybe 6 inches apart. And then I also observe for square wave jerks. The other thing I always want to do is check for convergence and insufficiency, because it's one of the most common ocular signs in concussion. So you want to look at their ability to converge at a target to about 6 inches, what that near point of convergence is. And a lot of times you'll see an eye that will just go out. One eye will stay in, the other eye will go out. And that's called an exophoria. So look for those things. So I don't have to mention that people who are dizzy are not happy. If they're nauseated, it makes it difficult for them to want to eat. Or if they're really nauseated and they're throwing up, I've treated patients that are throwing up 20 to 50 times a day, and that needs to be managed medically, sometimes with medication. But as soon as possible, you've got to get them off that medication so you can rehab their vestibular system. A lot of these people are coming in on meclizine, and that's the other thing is I found that when people are on meclizine, it's a vestibular suppressant, and they can't usually rehab their vestibular system if they're on meclizine. So if you overstimulate someone, you're going to make them dizzy. But the part of the treatment in this case is you are planning on making them dizzy. Nausea, we'll talk about in a minute. So with nausea, there's a lot of factors that can be involved. Obviously, pregnancy is a big one. If people are having a sudden onset of nausea with no trauma, it could be a stroke. You know, you look at age and other risk factors, but it also can be infection or toxic as well. Migraine headaches, vestibular migraines commonly have nausea and dizziness as a symptom. And then, of course, motion sicknesses a lot of times drives this nausea symptom. I've seen it in anxiety, and we see it in all sorts of GI distress with IBS, Crohn's, and constipation, and then specifically medication interactions. Many medications can cause nausea. Even supplements can cause nausea at times. If patients are taking supplements that you know they need, just have them take them with food, and it often decreases that nausea symptom. So what are the structures involved? We're looking at the vestibular labyrinth again. We're looking at the vagal afferents and the vascular system. And then centrally, we're looking at the area postrema, nucleus tractus solitarius, the vestibular nuclei, oculomotor nuclei, occipital and frontal cortex, and then the brainstem. The dorsal nucleus of the vagus also is related to nausea. So what do you do if you want to specifically evaluate someone who has nausea? Well, you look at their palate first. Actually, even before you look at their palate, you have them stick their tongue out, and then you see if there's any deviation, left or right. And usually the side that it deviates to, it's a medullary weakness on that side. And then you look at the palate. Always use a light, look in there, and you look at the palatal arches, and you just see if they're symmetrical. And then you have them say ah, and you look for that elevation of the palate. And if one side is lagging, you'll tend to see the uvula will shift to that side. That lifts a little bit more, but this is the side that you're mostly concerned with. So if you're looking in someone's mouth, if you're the patient for me and they say ah, and this side doesn't lift as much, that would be the patient's left side. We also want to check for the gag reflex and their swallowing reflex, and then check the bowel sounds. So here's a good image. You see the anterior and posterior pharyngeal arch. There's the symmetrical elevation when they say ah, and there's an asymmetrical elevation. Of course, that's the levator veli palatini muscle, and that will tell. This is the thing, you don't always know if that happened from that trauma. A lot of times people have chronic issues and then they get an injury and it just makes a chronic issue even worse, and then it becomes symptomatic. So I still treat what I find. All I can do is observe what I find and then treat what I find and see if it gets better. If it does, then you know you're on the right track. One thing we do for nausea is we give aggressive vagal nerve exercises. We have people gargle for 60 seconds several times a day. We have them stimulate their gag response unilaterally or sometimes bilaterally if they need it, several times a day. And I have them do a special exercise called tongue protrusions with neck extension, which basically looks like this. Stick your tongue out. You can try this at home. Tip your head back and try to swallow. And then they do that 5 times, at least a couple times a day. Have people sing loudly in the car and do circular breathing. And circular breathing is something I learned as a trumpet player in college and high school. And basically, you basically blow out slowly, fill up your cheeks while you quickly breathe in through your nose, and then you keep blowing out. So you get a a long exhalation. And basically you can look online for some YouTube tutorials for this. But what I'll do is I have a handout that I give patients, and I have them blow into a straw and just make bubbles in water. And then I see if they can start with maybe 15 seconds of bubbles, and then if they can go to a minute, and sometimes 3 minutes. It's just very difficult to coordinate. And so if they're trying to do it and failing, it just really helps help their cerebellum and their brainstem at the same time. It's probably one of my gems right there. The tongue protrusions and the circular breathing really help activate those areas. All right, you guys doing okay? Good. Let's talk about a few more clinical considerations for nausea. So if someone has nausea and they had brain injury, perhaps, maybe they have gut-brain dysregulation, but they also could have an eating disorder. So you need to ask about that, making sure they're not bulimic or anorexic, and then make sure they're digesting their food. A lot of times, if they have a brain injury and they have decreased vagal function, that means their digestive enzymes aren't enough. And if they don't have enough digestive enzymes, then they're not going to be able to digest their protein or their carbohydrates or their fat. A lot of times they're burping multiple times an hour, just constant burping after they eat or even during eating. And then once you get their digestive enzyme supported and their gallbladder supported, all of a sudden that will go away, and immediately the nausea goes down right away. So consider that. So another thing, if you start to do these gag responses or these swallowing exercises or teach them these things and they start to get these coughing fits, you've probably done a little bit too much. If people start to feel dizzy, they start to get a headache, or, heaven forbid, they start to vomit, then you've done too much. So just get them down, make sure they can breathe properly, and then you got to start on some other areas. Maybe you just do some very, very light humming exercises, or just some relaxed breathing, and get them to calm down. Make sure they get enough oxygen in and carbon dioxide out. All right, so what do you do in light and sound sensitivity? Well, the light and the sound sensitivity has to do with people that have commonly, we see this so often in traumatic brain injury. I see it in POTS. We see it with patients who have anxiety and insomnia, people who are dizzy, and a lot of migraineurs have it. So these are the common histories that we see, and the structures that are involved are pretty obvious. If your pupil is constricting improperly, then that's one of the peripheral structures that needs to be controlled. Obviously, your tympanic membrane, your tensor tympani muscle is innervated by a branch of the cranial nerve 5, and then your nerve to the sapedius also helps dampen the movement of the tympanic membrane, and that is cranial nerve 7. And then your auricle is your ear bones, and then your auditory nerve. These are all the peripheral structures that can be affected. Centrally, you have the colliculi, the superior and inferior, which is the back part of the midbrain, and then the medial geniculate nucleus of the thalamus, the visual cortex, temporal lobe for your auditory cortex, primary and secondary, and then of course your Edgar-Westphal nucleus is your parasympathetic nucleus that sends a signal out to the pupil to help it constrict. So there's the auricles, tympanic membrane. This is just a magnification of the external auditory meatus there in the inner ear, middle ear. See the eustachian tubes there, and the jugular vein is very close. A lot of times you'll hear people will complain of pulsing that they can hear, and that jugular vein is just really close. There's the stapedius muscle connecting to the stapes, and then the tensor tympani attaches to the malleolus and just helps dampen the amount of transformation that occurs from the sound as the sound wave comes in and moves those little bones. So what do you do to evaluate for this? Well, we've talked about the pupillary constriction. We usually have just turn off the lights in the room, turn off the TV in the background, and usually the computer stays on, so we'll have a little bit of light, and you just shine a light on there and shine it off, and you can see if that pupil constricts very easily. If you shine it on and it actually dilates with the light on, you know that there's some autonomic dysregulation, sympathetic overactivity, and then you need to find ways to dampen their sympathetic state, which is very challenging to do sometimes, but you can do it. And then one thing I like to do, if they have pupillary constriction, it just reminds me that that tactile response is overactive. So we'll also check for their slightly lower area of the brainstem, the inferior colliculus. And we basically just hit the 128 hertz tuning fork, stick it by their ear about an inch or two away, and just see what they do. We look for some kind of grimace or a pull away. And if they do, then we know we need to do something to help them not be so overreactive. So I'll show you a video of that in just a second, but I like to use the binasal occlusion glasses, which in my office, we just bought some Solaris blue blockers, and then we just put some tape, some black electrical tape just on the medial nasal field. And I learned this from Deanne Fitzgerald and Charles Shedlovsky, amazing visual therapists. And it's just changed so many patients' lives to have that little therapy to help them not be so light and sound sensitive. Sometimes if that doesn't work, you can plug one ear, the one that's more sensitive, for 15 minutes to a few hours a day, just to dampen the amount of feedback they get in. And then I'll explain the horizontal slingshots and the gaze stabilization we've already discussed. So here is a patient that, let's go back.
Okay. Sorry,
So we just put this tuning fork next to her ear, and that's the right side. She did not like it. And I think she hated it a little worse on the left. And then we put the blue blocker glasses. I don't know if you can see the binasal occlusion, but she still didn't like it, but it was less of a dramatic response. So I might try that a couple times, leave that on her for a few minutes and see if it helps her tolerate light and sound. Sometimes you just put that on for 10 minutes, have them do some breathing exercises, and you recheck, and things have just dramatically improved. So you know you're on the right track with rehab with those glasses. So this article is a article entitled Binasal Occlusion, Visual Motion Sensitivity, and the Visually Evoked Potential in Mild Traumatic Brain Injury. And this was basically just showing some of the different, in this particular case, some of the pictures you see in the paper, they don't even use the blue blocker glasses, but I just like to use it because if they're sound sensitive, they're usually light sensitive and vice versa. So what do you have to be careful of in your metabolic capacity considerations? Well, when you stimulate that tuning fork or you shine a light in someone's eye and they're feeling like they don't have ability to tolerate it, it will, whatever symptoms they have, it can make those worse. So it can cause them to get a headache. It can cause them to have tearing. It can make them socially to want to seclude themselves. A lot of parents with young children who have traumatic brain injuries, their kids, in their words, are so loud they have to just get themselves isolated in a room, and they can't even be around the normal noise of a child. And they'll also, this starts to affect their emotions. They'll snap easier. They're more angry. They just don't have emotional stability. And then you can always refer back to slides 9 and 11 for some of those other scenarios. So basically, that summarizes what we're going to, what I wanted to talk about with you today. I've listed some of the papers here you can find. If you want to search through this website from the University of Utah Medical Center, they have an amazing website that goes through the normal and abnormal coordination exam, and it is, you should understand it, go through all those, and just to review. And basically, that is all I have for you. Thank you so much for joining me today, and I look forward to spending the rest of the weekend with you guys learning from some amazing speakers. All right, thanks a lot. So I hope you guys have a great day.
All right. Well, Dr. Smith, thank you again so much for being a part of this year's conference and all the information that you shared with us. With all those books in the background there, I know that you're an avid learner and you've probably figured out some amazing ways to retain this information. Could you share with some of our learners some ways that you have found that have made making this stuff stick or more plastic in the brain a little bit easier for you?
Yeah, I mean, I've done so much education and so much learning the past, even since I finished chiropractic school, that I've just been really frustrated at times with why I'm not able to retain it. And so what I've done is I've made I don't know, a study on how to learn. And I've, you know, definitely tried to learn how to make neuroplasticity happen with patients, but I've definitely wanted to make my own brain healthier. And so what I've put together is just a little research that you can, let's see if I can share my screen. If you look at this little video of my granddaughter about a year ago,
Hi.
you can see she's just barely starting to learn to walk. And it's always so fun to see a little baby learn to walk that it just makes, it's just so much joy. And if you notice, what we're doing in traditional learning is it's crazy how we force ourselves to learn. First of all, we isolate ourselves away from everyone so we don't get interrupted, and then we deprive ourselves of all sensory input, and then we sit there in one place and we don't move around, and it's all based on whatever this teacher decides I need to know and learn that, and then they give you that information, and then there's a whole bunch of written tests, and then you just procrastinate because you're so busy and trying to learn so much, and you cram it in, and then you of course quickly forget it all. So if you want to learn how to learn, I really recommend this course by Barbara Oakley. It's a free course on Coursera.com, and it basically talks about the two different learning styles, how you can have diffuse learning or focused learning. And between going through her program and learning some of the other things from some of these other courses, I basically put together 5 ways that I think is a beneficial way and a helpful way for me to learn. It's been good for me anyway. And the first one is just to follow a path. You see my son hiking here up in the Uintas in Utah, and it's just beautiful as long as you stay on the path. If you get off the path, you get a little dangerous. So you stay on a track and you do it steadily and consistently. And then the second one is you visualize and draw your knowledge. With all the technology we have, everything's just so easily accessed, and we're not taking notes as much as we used to. But if you do take time to draw things out, it will cement that knowledge in your brain. That's sort of goes into point 3, which is how it's important to learn spatially. And that means you take things with your body, you make diagrams, you make charts, you make flow charts, you reword the things that you're learning, and you put it into something that makes sense, where you can review it and cement that in your brain. And the fourth thing is it really helps to learn socially. If you have someone that you're a study partner, an accountability buddy or something that you're like, look, let's study this topic for this amount of time, and then you once a week check in and you share what you've learned. If you don't share what you've learned, it really accelerates the amount that you'll forget. So that's one thing that I've loved having a chance to teach, because I really learned this material a lot more deeply. And then the 5th one is really critical. It's the chain over here. You have to link what you're learning to something that you already know. So maybe you understand how bungee cords work, or rubber bands, or block stacking. There's just find ways to link physical truth in your mind to what the new things you're learning, and you'll find that all of a sudden it just sticks there, and then you're not wondering, hey, what was that thing I learned? So if you follow a path, you visualize your knowledge, you learn spatially, you learn socially, and then link your learning, and then just share it to people, teach it. You'll find, and of course, if you're seeing patients, you have a chance to teach it to your patients every day. So every single day I'm studying a little in the morning, a little bit at night. Sometimes it's only 5 or 10 minutes, sometimes it's an hour or 2. But I always share what I'm learning with my patients, and and I tell a story about that thing that relates to them. And it seems to make a big difference. They seem to like it. They have fun with it. And then they start to benefit from the things I'm teaching them.
Well, that's awesome. Thank you so much. And can you just show that website one more time for people on the first slide from
The
Coursera?
website, this is amazing. It's Coursera.com. And this one is probably one of the most watched courses that's ever been. It's been watched by multiple millions, but it's called Learning How to Learn by Barbara Oakley. And it's just really nice because it's a brain-based approach on how to maximize your learning. And, you know, it'll take you, I don't know, 14, 18 hours to go through it, but I just went through it 30 minutes a day, and there's little videos and little quizzes to help check your learning, and it's a fun course.
That's great. Thank you for that resource, and seriously for all the information, and of course all that you do for IAFNR. Thank you so much for volunteering your time on the board, and we look forward to what's in store for the next year. So thank you so much.
Hopefully we can get to do something in person, which is
Yes,
part of the social learning and
social
making
learning.
connections.
Absolutely.
Awesome.
Thanks so much, Doc.
My pleasure. Thanks.